afternoon. My name is Peter Schneider, and we're here at the VEITHsymposium held the week before Thanksgiving every year. And once again, this year's meeting is amazing. Everything under the sun that happens in the vascular world is being discussed here during this week. And I just happened, oh, wait a second, is that Frank Veith I see in this crowd? No, I just want to introduce, these are three people that I respect. I'm lucky to have them in my professional life, and these are three of the world's experts on carotid disease. Dr. Wes Moore, UCLA, who's done so many things over the years to really help us define and understand carotid disease. Frank Veith, who has gotten the vascular world together once a year to discuss these things amongst the many accolades. And this is Samara Mcdonald, who, in my opinion, is one of the leading neurointerventionists with a PhD in carotid stenting, for goodness sake. So if there's anybody that understands carotid stenting. So we have a few minutes to talk and to get together, and I just wanted to get a sense from, obviously Frank designed the program, but the three of us are attending the program. So I'm going to throw it to you, Wes. Did you see anything this year you were really excited about, interested in with regards to carotid disease? Anything new?
Yeah, I think there were a number of sessions that I was particularly intrigued with. First of all, the session that had to deal with intensive medical management, I think was particularly compelling. And the fact is that we can really manage patients a lot better medically than we have in the past. And that is either as a standalone therapy or as a complementary therapy to intervention, be it carotid endarterectomy or carotid angioplasty. The second area that I was particularly intrigued with was the continued reaffirmation that the transfemoral approach to carotid artery stenting carries twice the risk of stroke and death as does carotid endarterectomy. And that continues to be a recurring theme. One of the things that we saw on the carotid session yesterday was a report from the Canadian group, which, contrary to other studies, have shown that the difference between morbidity and mortality comparing carotid endarterectomy with carotid stent angioplasty actually continued to diverge. And that's contrary to other studies that we've seen in the past. And I'm a little bit concerned about that because my feeling is that if we can figure out a way to avoid the periprocedural event rate with carotid stent angioplasty, that as long as the curves remain parallel, then carotid stent angioplasty would be competitive with carotid endarterectomy, with the exception of the periprocedural event rate. So that's one of the things I think we're going to have to keep an eye on.
Yeah, that makes sense. Very interesting. And Frank, obviously you put together some debates. You are not immune from having stirred the pot a few times yourself. Do you have a sense of where carotid endarterectomy is going? Is it going to be a big part of our future, a small part of our future? We have competing technologies now.
Yeah,
what do you think?
I think both carotid endarterectomy and CAS have relatively bright futures. But the most remarkable thing that I heard was by Ron Waxman and Dave Spence commenting on the new trials with the PCSK9 inhibitors, which actually could make the plaques in the coronary arteries and the carotid arteries get smaller and less threatening. So to me, that was new information. We'd always suspected it, but this has really been proven. So it expands on what Wes was saying, that medical treatment really has an impact and is changing the whole scenario. But I think with the transcervical approach for carotid stenting, the new membrane and mesh covered stents, we're going to see a reinvigoration of carotid stenting.
So this is now new technology, which is of course being discussed here at the meeting. The data for the transcervical approach, so-called TCAR, is starting to mature now. I would say we have a lot of patients who've had that procedure. I have to tell you, in the fall, Dr. Moore had invited me to speak on carotid stenting in general at the UCLA postgrad course, and you probably remember this. At the conclusion of my discussion, we had a little panel, and one of the questions to Wes and me was, if you needed your carotid artery fixed, how would you have it done? And Wes said he thought the data for TCAR was strong enough that if it plays out, that this could be a potential. So you were talking about it almost as if, wow, this is competing with endarterectomy. Do you still feel that way? Or
yeah, very much so. I used to, in speaking with patients, would advise them to avoid carotid stent angioplasty, particularly from the transfemoral approach. But the data from the transcervical approach, or TCAR, are really compelling. So now when I see a patient who needs a carotid artery ablation, I will offer them both approaches. And some patients are very enthralled with the idea of the less invasive approach that TCAR can afford and will select that. Others are more enamored with the idea of physically removing the plaque, and they'll choose that. So I do believe at this time we have true alternatives available that we can offer patients with equally good results.
But I thought one of the other very exciting things, Samara, you had some new data that you presented with the membrane or mesh covered stents. You want to tell the world about that?
So for the purposes of full disclosure, I'm the Chief Medical Officer of Silk Road Medical, the company behind TCAR, Transcarotid Artery Revascularization. And yesterday I talked a little bit about TCAR, but I also focused on the other new technologies, membrane mesh stents. The problem, as you've said, for transfemoral stenting is a navigation of the arch and its embolic burden. And furthermore, the off-table strokes that we think may be related to plaque prolapse through stent interstices, that minor stroke excess that plagues transfemoral stenting between on-table and day 30. So membrane mesh stents really formulated to deal with that potential problem. The problem I have is that the scaffold data, which was the IDE for W.L. Gore's EPTFE heparin-bonded nitinol stent, it was presented at Charing Cross, showed just a low stroke rate. 9 of 312 patients had a stroke, but 6 of those were off-table. So that is not really doing what we would hope for.
Yeah, but don't you think that's a little premature?
Yes, we need some maturing
we need
data.
More.
We need some maturing data.
And more data with the other two membrane-covered stents.
We do. So the Confidence trial is running its IDE. That's the microvention road saver stent. So it'd be nice to see what the results of that look like. The other thing I showed was that a TCAR has a very low new white lesion rate after intervention, which is commensurate with CEA.
You're talking about white lesions on DW
MRI imaging of brain, and whether or not mesh stents can be additive to transcarotid artery revascularization techniques in terms of further stroke reduction in new white lesions is unknown. But the happy problem to have is that our stroke rate is so low. It's difficult to see how we can bring it down any further.
Yeah, no, I think the mesh covered stent approach makes a lot of sense, and this is not terribly dissimilar from actually resecting the carotid bulb and putting a PTFE graft in. It's the same material. It's heparin bonded. The results of that, of at least the replacement with a PTFE graft, are really exceptional, and recurrent stenosis rates are very low. So I think that the mesh-covered stent, particularly heparin-bonded PTFE, really offer a great deal.
But it's interesting also, the debates go on. And there's no question in my mind that all of us are biased, and some of the specialties are biased towards the techniques that they most favor or most experienced with. So I think we'll have even more interesting debates maybe next year. What do you think about that,
Well, I
Peter?
think it's right. I mean, I think I got very interested in mesh-covered stents early on, and I should tell you I've gotten to be the co-PI for the scaffold and the confidence, so I'm seeing the data accumulate as you're hoping it will. I think also, I think there's some definite potential there to make
do you see differences between the 3 different brands?
Yes, each one has a different pore size, and much like we went through with the distal filters for carotid disease, even though that's a little bit less in favor now than maybe, say, in its earlier time frame, I think we did struggle a little bit with those different filters. They each have a little bit different catchment rate. You make the filter too porous, higher risk of events.
Right.
Don't make it porous enough, then it's a higher thrombotic
So
risk.
it's still,
I think it's the same.
Still undecided.
It's undecided,
Yeah.
so we'll have plenty
The jury
to talk
is out.
about. Yeah. One thing I wanted to just go back to Sumaira just for a moment is, Wes has done a lot of T-CARs. I've gotten to do them too. And I was just wondering, you probably looked at more should we do it, should we not, T-CAR cases than anybody. Could you just give a little, like, how do you look at those? Like, who's not a candidate? Who should not get a T-CAR?
Well, at the end of the day, even though TCAR allows you to deliver a stent safely and reduce that peri-procedural hazard, we do have some requirements to do with the common carotid artery. So the cut down is a small cut down, as you both know. As you know too, Frank, just above the clavicle. It's much smaller than the incision for CA, but we need 5 centimeters of working length from the clavicle to the lesion or bifurcation for obvious reasons. And we need it to be disease-free at the clamp zone and what we call the stick zone, the access zone for the common carotid artery. So those are absolutes. The diameter of the common has to be 6 millimeters to safely accommodate the arterial sheath of the neuroprotection system for TCAR. And the other consideration is, at the end of the day, it's still a stent-based treatment paradigm. So lesions that you wouldn't stent transfemorally because of calcification should not really be offered a TCAR procedure. Heavy calcification.
So lesion-related issues are, it's still
Very
a stent in the
heavy
carotid.
But it's important to point out that the T-CAR, your system, Silk Road, also offers the advantage of very efficient reversal of flow.
Yes.
So that is probably the best cerebral embolic protection system that we can get during the procedure.
That's certainly the best I've used before I became
Yeah.
Chief Medical Officer, which is one of the reasons why I'm the Chief Medical Officer of the company. And I know it's anecdotal, but we often, you probably have someone cut the filter open, the external filter, and the sort of debris that this thing can accommodate is eye-opening.
Yeah.
It's really quite scary.
Whereas the other, the MoMA device, for example, it ceases flow. It doesn't reverse it.
It ceases
So
flow.
this is a better system. One of the reasons I think the future for carotid stenting is bright is because of your system and these stents. And we're getting better at picking the patients that should be done.
Yeah, I mean, I used a lot of MoMA before I moved to doing TCAR, and you get a standing column of deoxygenated blood, which I don't think is best
You have to
tolerated
aspirate the
in the majority.
junk out.
I don't think the brain likes that deoxygenated blood, but flow reversal kind of washes the hemisphere with oxygenated blood. It's completely anecdotal.
Yeah. So I think, I don't know about you guys, but I'm missing a session right now.
Go
here
to
at
your
the
session.
meeting. So
We can't let you miss the session.
But I do want to thank you for sharing your thoughts and opinions with me and with everyone else. And I think this has been a really, really interesting little a chance to share a moment on some of these new technologies in carotid disease. Really exciting future, I think.